Thank you, Victor. Thank you, Ricardo, Ricard, and Luis for inviting me. It's an honor for me to be here. Sorry I cannot speak in Spanish, but I'll try to make the pictures easy enough for you to understand. All right, so I'm going to discuss with you a common patient that we all see, whether we are pain doctors, internal medicine doctors, emergency room doctors, geriatricians. We all see these people who like to sit. Wherever they get a chance, they're looking for a chair to sit down because they cannot stand. Or they go shopping and they like to lean on the shopping cart. Do they have shopping cart in Corte Inglés? They do? Oh, okay. I didn't see. Or they become eventually depressed, like this lady here says, I cannot walk anymore in the mall. And I'm unable to stand and do the dishes. You know, there's still some people, old style of thinking, they like to do the dishes with hand. So this is your typical spinal stenosis patient. And there is about 2 million of these patients that are currently diagnosed and in treatment in the United States alone. So it's a big problem, as you can see. It does affect people starting age of 50 to 60. That's the range that it starts. And it gradually gets worse. And there's always other cofactors like facet arthritis, like degenerative disc disease, and foraminal stenosis. All right, so how do we identify these patients? Again, I'm going to repeat this so many times. They have pain in the lower back with some numbness going down if they stand or they walk for a while, okay? And the pain goes away if they lean forward or they sit down or lay down. This is the hallmark of what we call neurogenic claudication, which is the main symptom of spinal stenosis, central spinal stenosis. So it's a mobility issue, okay? And the patients try to avoid or limit their mobility. So it affects their quality of life eventually. All right, so how does this happen? How does this spinal stenosis happen? In a normal people, like Luis here, as you can see, the spinal canal is wide open. So the nerves, the cauda-equina nerves, or at the higher level, the spinal cord is not under any pressure, okay? It's wide open. And they don't have any impingement on the nervous tissue. Now, in people like me, if we start getting old, that's the MRI on the sagittal view on a T2, and here's the axial view. You see this thickness of the ligamentum flavum? So they start getting narrowing. What does narrowing do? Every time you compress something, you're depriving it from blood flow, right? So the blood flow is interrupted, and they get edema. Okay? And that's how they get pain and numbness down their legs, the back and the legs. So this is how it happens. So remember, it's from edema and lack of blood supply. Now, the mild procedure that I'm introducing you to today, it's a procedure that has been around since 2010. For the last 2 years in the United States, Medicare tried to stop this. They said there is not enough literature. But they agreed to sponsor a study, which I'll present you the results of which was published 2 weeks ago. Okay, so this is brand new. The mild procedure, what it does is a minimally invasive procedure that decompresses the lumbar spine and takes away the narrowing. So it opens it up. Without general anesthesia, without being admitted in the hospital, and as you can see, it's guided by fluoroscopy, and I'll elaborate a little bit more on it. So this is what happens. This is before, and this is after, okay? So here you see the green is ligamentum flavum. As you can see, the thickening of the ligamentum flavum here causes narrowing of the spinal canal. And after decompression, you see the spinal canal is open. Now, the decompression happens through a small port that is only 5.1 millimeter. So there is no incision. It's a hole. Okay, so this procedure, the hallmark is this procedure is its safety. And I'm going to tell you why it is safe. And it's safer than even open surgery. Okay? So the procedure, as I told you, is done under fluoroscopy, and everything that is done is posterior to the dura. Now, you need to do an epidurogram. Epidurogram is doing interlaminar epidural, which a lot of us know how to do it, very simple. And then you inject contrast. When you inject contrast, there you go. You see, the contrast goes. So when you're doing the procedure with this is the instrument, you know this is the border. You're not going to cross this, right? In an open surgery, you don't have this. You don't know where is the border of the dura, okay? So this is the hallmark of this procedure. There is a safety barrier. And, by the way, this is what happens after open surgery. This is the hole that's left, 5.1 millimeter. Now, here is the spinal stenosis, as you can see, ligamentum flavum, okay? And this is the cadaveric section. There is the ligamentum flavum in yellow. This is how you can, the red is bone, okay? So you remove some of the bone from the top, some of the bone from the bottom, and then you decompress the ligament with the instrument that's provided. So that's how the procedure is done. You debulk the ligament. There you go. And you don't take it all the way, right? You leave some of it behind, which is that. This is the device kit. It's a disposable kit. Used to cost about $1,500. They're all disposable. And this is the different steps of the procedure. I don't want to go through all the details, but this is where you place the portal. That's the 5.1 millimeter portal. And that's your Tuohy needle with the epidurogram, because you need to inject contrast during the case so that you know you don't miss the line, okay? That's the key. If you cannot do the epidurogram, you cannot do the procedure. All right, now, something that's different with this procedure, and you need to get used to this view, fluoroscopic view, is the contralateral oblique. And contralateral oblique is the best way of looking at the depth of the needle, even better than lateral. So contralateral oblique is better. That's the view. You see? There's your needle, and that's your contrast. So if you want to see the depth of the needle, you have to do contralateral oblique, unless the spinal canal is perfect square. If it's not perfect square, then you have to do contralateral oblique. How many degrees? 40, 45 degrees. Usually, this degree, this line, should be parallel to this lamina to have a perfect view of the depth of the needle. And that's where you inject your contrast. And you do it throughout the procedure. There you go. This is the AP view. You've seen this in people who have spinal stenosis when you inject contrast, very narrow, right? Distribution of the contrast. And that's what you see. There is no contrast going up, right? So, and then you turn into contralateral oblique, and here's your instrument. There you go. Different kind of instruments. This is the bone rongeur that you can go either this way or turn it and pull that way. So you can remove the bone with this rongeur. And that's how it's done. And then, once you remove enough bone, this is called tissue sculptor, that you can remove parts of ligamentum flavum with this. Okay? So, this is the cartoon for this real picture. This is Dr. Vallejo doing the procedure. So, this is the, as you can see, there is no contrast because of severe stenosis. And you do the procedure, and then when you're done, you inject contrast, and you see it opened up. It's decompressed. And that's the cartoon for it. So before and after. Now, let's compare this to surgery. One of the most widely referenced studies in surgery is called Sports Study by Weinstein, okay? And so I'm going to compare the data between the two. Now, so mild procedure is done under IV anesthesia. Open surgery, definitely general anesthesia. And you know, doing general anesthesia in old people in the prone position is not as well tolerated, okay? So the incision, there is no incision with mild. There is that 5.1 millimeter hole. Incision in the open surgery could be 2 to 3 inches. Visualization, because this is a matter of safety, right? Those of you who have been anesthesiologists, you know that you're doing a case for a spine surgery. Sometimes you see, oops, the surgeon goes, oh, the dura is ruptured, so the field is flooded with CSF, and now they have to do a dural tear, okay? So here you have a direct visualization of the depth of how far you take tissue. In open surgery, you're looking straight. You have no idea how deep the ligament is. So they start taking with rongeur, bone and tissue, and then without knowing how much is enough, right? Now, there you go. The key is the dura. Mild procedure is done posterior to dura. How do we know? Because we have an epidurogram that shows us the border, right? Open procedure, dural puncture is very common. I'll show you the statistics very soon. So now, with the mild procedure, as far as bone and tissue removal, as you can see, you only remove enough to improve the flow of the contrast, and you stop. With the open surgery, you have no idea. There is no interaction. There is no way of knowing how much is enough. Actually, some surgeons will take pieces and go show to the patient's family, say, wow, look how much I removed. So incision, there is no incision, okay? Now, this is the statistics from sports study published in New England Journal of Medicine in 2008, okay? They had 394 patients in the study. So far, we have had 12 studies in mild that has 887 patients in them. So this is what, it's not a direct comparison, to be fair, but I want to show you something. 0 dural tear, 0 blood transfusions in all of these 887 patients. Okay, bless you. Now, this is sports study, reported 9.2% dural tears, 14.3% bleeding requiring blood transfusion. That's pretty significant. And you can see here overall complication. There has been over 20,000 mild cases done. The overall complication is less than 0.1%, and the complication is very simple. I'll show you. Overall, open surgery complication is over 20%. Okay, how about cost? Everybody talks about cost and all that. Hospital stay with mild, it's same day. They go home the same day, within hours. With open surgery, 3 to 5 days. I don't know what is here, but that's what it is in the United States. Anesthesia is IV sedation, MAC, versus general. Procedure costs about, I would say, $4,000 or $5,000 versus $25,000. So almost 1/5, 20% of the cost of surgery with less complications. So we're not counting here the cost of complications that are 20%. Okay? This is just the cost of doing the procedure, not cost of complications. And these are old people, remember. It's more difficult in these people to do the rehab and everything else. All right, so this is an FDA-cleared device, over 20,000 cases. There has been 12 clinical trials with 887 patients done. There has been 18 published peer-reviewed articles from year 2010 to 2016. That's a pretty good number of patients. And it's a safe procedure. Now, I told you that this study was just published 2 weeks ago, okay? So let me give you a little bit insight on how this happened. So who is Medicare here? Who is the entity who is like, do we have something like that? Is it the government or? Government, yeah. Government knows how to practice medicine. So I gotta say something. So, so in the U.S., Medicare, who controls, for old people and disabled people, it's 28% of U.S. Budget goes to providing care for Medicare and Medicaid, 28%. The defense budget is 16%, just to give you a perspective, okay? So they said, no, we're not accepting coverage for mild procedure, okay? And then, but a bunch of us went in front of Medicare and argued that, hey, this helps people. 20,000 people have had this. And this was during the time that there were changes happening, so they agreed to do what is known as coverage with evidence development. So they agreed to pay for patients in a study that protocol was approved by them, a randomized trial, okay? So the trial started enrollment in June 2014. Dr. Vallejo was one of those 26 centers in the United States. 26 centers did this in the United States, okay? And by April 2015, enrollment of more than 300 patients was completed. Pretty good speed of enrollment, okay? And then in February of this year, the 6-month follow-up was published, and in May, like 2 weeks ago, here you can see this was the 6-month result, and this is a 1-year result that was just published 2 weeks ago. And you can, if you go to Pain Physician website, you can download it for free. All the articles are free. Okay, so the study was randomized, controlled trial, multi-center. The controls were epidural steroid injections. So this treatment was for spinal stenosis causing neurogenic claudication, okay? And only in Medicare patients, meaning older patients, and this was studied, okay? Now, the randomization was 1-to-1, and patients were allowed in the epidural group were allowed to have up to 4 epidurals for 1 year.
Told me to tell you 5 minutes.
Oh, okay, thanks. I thought you were saying no, there were 5. I'm like, I wouldn't be surprised. He might know it better than me. All right. Okay. So 1 year follow-up with the primary endpoint being the Oswestry Disability Index. So we looked at the responder rate, okay, at ODI. Secondary was numeric pain rating scale, okay, and then another secondary was the Zurich claudication questionnaire, different domains of it. I'm going to show you. And as I said, 26 centers, basic characteristics pretty much the same. As you can see, cofactors very common among all the patients. So this was the flow of the patients. 320 eligible, 302 enrolled, randomized, which is that's also a good number, okay? This was all interventional pain doctors who have done many of these procedures in the past, okay? So there you go, at 1 year follow-up, 129 from the epidural group were included and 143 from the mild group were included. And this is it. This is the most important slide, is the primary efficacy, the percentage of the responders with ODI. Responders were all those who had 10 or more points improvement in their ODI. And as you can see, the blue is mild group and the orange is epidural. I mean, there is no doubt that it was statistically significant. And this was also true along all the numeric pain rating scale, as you see, 57 versus 27, and all the Zurich different domains. We had statistically significantly higher percentage of responders. Now, those of you who are interested in see the mean change, this was the mean change. The mild versus epidural in the ODI. The mild was 16.2 points reduction in the mean. That is very significant for pain studies. It's usually 12, okay, to be significant. And this was the Zurich. Again, this is the numeric pain rating scale. And Zurich, there was one complication and he caused it. Patient became vasovagal. but you know how the protocols are. Because patient became vasovagal, so they have to admit the patient in the hospital for observation. If you admit the patient into the hospital, then it becomes a serious adverse event. That's how these things are. All right, so in summary, you know, this was a level, we would like to call this a level 1 evidence that supports the efficacy and safety of mild procedure in treating spinal stenosis that produces neurogenic claudication. Now, in the past, we either did epidural and more epidural and more epidural and more epidural, and then when everybody gave up, we'll go and have open surgery. Now, we might have an option in between epidurals and surgery. So I would like to quote Teddy Roosevelt. That's a good Roosevelt, by the way. It is hard to fail, but it is worse never to have tried to succeed. Thank you very much.